Scott Brown's Rhinology, Chapter 88, Outpatient Assessment. Here we'll learn about introduction, history taking, patient reported outcome measurements, PROMs, examination, and references. Introduction. Rhinology is an increasingly broad subspecialty in which outpatient assessment is adjusted to suit each individual case. This chapter explores basic rhinologic history taking, clinical examination, nasoendoscopy, and use of patient reported outcome measurements, that is PROMs, interpretation and use of most specialist assessments such as rhinometry, facial pain, and lacrimal testing are described in their respective chapters. Investigations are described in their respective chapters, for example, measurement of the nasal airway and radiological imaging in rhinology and skull base surgery. The aim of an outpatient assessment is to reach a diagnosis in order to guide management. In many patients, this may be clear from the history alone. History taking. This is best initiated by characterizing the index nasal symptoms, noting duration, periodicity, nocturnal variation, seasonal effects, laterality, association with trauma or prior surgery, and whether there are any alleviating or provoking factors. The inquiry should cover the presence of nasal obstruction or congestion, facial pain, hyposmia, anosmia, rhinorrhea, and postnasal discharge. Secondary symptoms such as sneezing, itch, epiphora, taste disturbance, and dry mouth should be elicited where appropriate. Understanding the symptoms and their association is not only useful diagnostically but also helps to create a picture of the level of quality of life impairment suffered. The character of any nasal discharge can give clues to an acutely infective mucopurulent versus chronic rhinosinusitis or inflammatory origin. Increasing unilateral nasal obstruction associated with epistaxis, often minor, or facial pain and swelling suggests neoplasia and indicates the need for urgent assessment. It is important to inquire about allergies, hay fever, exposure to animal dander, asthma, or more general respiratory symptoms, and aspirin hypersensitivity. A previous history of nasal trauma may suggest nasal obstruction resulting from septal fractures or dislocation causing obstruction or failure of support to the internal nasal valve. Surgical procedures such as rhinoplasty, alar based reduction, and cleft palate surgery may all be associated with similar restrictive changes on the nasal airway. Many systemic diseases have nasal manifestations, granulomatosis with polyangiitis, previously veterinous granulomatosis, is a systemic vasculitis in which nasal obstruction is associated with diffuse crusting of the nasal mucosa. Other conditions such as sarcoidosis, Church-Strauss vasculitis, and Behçet's syndrome have a similar presentation. Cocaine abuse and habitual nose picking can cause septal crusting, septal perforation, and saddle deformity, all of which have potential to cause nasal impairments. Immunodeficiencies and ciliary defects also commonly associated with nasal pathology. A history of cigarette smoking is relevant as it may potentiate allergic rhinitis and vasomotor rhinitis. Is sometimes seen as a cause of nasal obstruction during smoking cessation. The psychological aspects of the history are important to address. Many rhinological symptoms related to stress, anxiety, and psychosomatic manifestations. Directed inquiry into work and home situations will often elicit a patient's own concerns to this end. Previous and current therapeutic trials of medication and their efficacy should be recorded. Many drugs exacerbate nasal symptoms, especially common are those with anti-muscarinic effects such as the antiprosthetic medications, anti-epileptics, antidepressants, antipsychotics, antihistamines, and drugs for Parkinson's. Non-steroidal anti-inflammatory drugs (NSAIDs) such as aspirin and ibuprofen in patients who have Santer's triad, nasal polyposis, asthma, and NSAIDs intolerance can trigger a non-infective rhinitis and rhinosinusitis. Nasal obstruction associated with vasomotor rhinitis is a side effect of a number of drugs, including antihypertensives such as beta blockers and calcium channel blockers, sedatives, phenothiazines, antidepressants, oral contraceptives, and drug used to treat the erectile dysfunction. Overuse of sympathomimetic decongestant nasal sprays can cause rhinitis medicamentosa. Patient reported outcome measurements measures PROMs. Contemporary practice should include the evaluation of the full patient presentation. This process is simplified by the routine use of PROMs, questionnaires that aim to capture and quantify the bulk symptomatology and disease impact. These should be supplemented and validated by direct questioning and inviting patients to discuss other ways in which they have been affected. When patients complete forms prior to the appointment, the administrative burden is minimized and the exercise will add to the efficacy and efficiency of the history taking process. Capture of these details, ideally digital, should facilitate research audit and service evaluation. The following are selected examples of the more prevalent and well validated patient report outcome measures that may be useful in rhinology case clinic. Examination: nasal structure or aesthetics. A full facial aesthetic assessment should be performed in patients with external deformity or cosmetic corners concerns. Examination of the external nose should begin with careful inspection and palpation of the nasal bones and alar cartilages. The details should include an evaluation of skin type, skin scars, soft tissue envelope thickness, integrity of the upper and lower lateral cartilages, nasal tip support, tip configuration, nasal nares shape, and integrity of the external and internal nasal valves. These factors can offer useful information on the more subtle causes of nasal dysfunction, such as nasal valve insufficiency, abnormalities of relevance to function, as well as cosmetic include saddle deformity, septal deviation, and deficiencies of the upper or lower lateral cartilages. Functional assessment or anterior rhinoscopy. Nasal patency is assessed through anterior rhinoscopy, examination of the anterior nose through a pterygium speculum, and headlight illumination. First, the patient is asked to breathe normally through their nose, noting any difficulty or noise. A thumb is used to gently occlude each nostril in turn and assess unilateral patency, remembering that many normal subjects are unable to breathe comfortably through a single nasal airway. The degree of alar margins or external nasal valve collapse is observed on normal and on forced inspiration. Again, noting that some dynamic narrowing is normal. The inferior turbinate should be evaluated for congestion, mucosal thickening, and presence of exudate. Table 88.1: select examples of more prevalent and well validated patient report outcome measures that may be useful in a rhinology clinic. Instrument, domain focus, PubMed citations, and licensing. The area between the inferior turbinate head, upper lateral cartilage, and the nasal septum is narrowest part of the each nasal airway, termed the internal nasal valve. The cross section area of this space should be assessed at rest on normal and forced inspiration. Any restriction may be due to septal deformity, turbinate engorgement, or internal nasal valve collapse. The latter may be static or dynamic due to upper lateral cartilage deformity or weakness, respectively. Static internal nasal valve collapse is associated with an acute valve angle at the junction of the septal and upper lateral cartilages, less than 15%. Poor septal support can also result in a shallow valve height with nasal restriction despite an even more obtuse angle more than 15 degree. Septal obstructions elsewhere in the nose can be classified and graded as shown in figure 88.1. Figure 88.1 Cottle's area of the nasal septum and the internal nasal valve region dotted line. Deviations of the nasal septum can be classified by location and by severity. Locations include 1. Caudal septum, 2. Internal nasal valve, 3. High mid septum, 4. Low mid septum, 5. Posterior septum. Severity is graded 0, no deviation, 1. Minimal deviation, 2. Less than 50% lateralized, 3. More than 50% lateralized, 4. Is fully lateralized. Mucosal contact with the lateral wall. This figure is released by simple tests such as the peak nasal inspiratory flow, nasal vapor condensation, or nasal valve splinting tests can be helpful adjuncts to confirm the clinical evaluation of the nasal patency. Cottel's maneuver testing for improvement in nasal patency with lateral traction on the alar tends to improve all nasal airways and is not advocated as a useful discrimination test. Other clinical tests can be helpful. Internal valve collapse may respond to a trial of breathe right strips. Similarly, nasal vestibules tend such as Franz alar dilators, air max nasal splints, or max air sinus sconds can have a positive effect on both valve areas. Figure 88.2 Nasal patency test A, B, a vapor condensation test can be performed with a metal tongue depressor or a Glaxel calibrated mirror and gives a ready reckoning of relative flow. C, a peak nasal inspiratory flow PNIF meter can evaluate overall nasal patency, normally more than 100 liter minute in an adult. D is the splinting test on the external and internal nasal valve can confirm anatomical deficiencies. Table 88.2 Nasal nasoendoscopic technique. First pass front to back. The endoscope is passed along the nasal floor, visualizing the septum and inferior turbinate. In the postnasal space, the estrition cushion and orifice and the fossa of Rosalmilla are seen. Any mucopurulent postnasal discharge drainage can be noted. On withdrawal, the inferior meatus and, where possible, Heister's valve are inspected. Second pass medial to the middle turbinate. Passing the endoscope medial to the middle turbinate, the sphenoethmoid recess, superior turbinate, and slit-like opening of the sphenoid ostium are visualized. The olfactory cleft is seen more anteriorly. Head repositioning may be required and an angled endoscope is recommended. Third pass, the middle meatus. Retracting, rotating the view laterally and rolling the endoscope into the middle meatus will medialize the turbinate into and expose any middle meatal mucopurulence, accessory ostia, or other pathology. The hiatus semilunaris bounded by the uncinate and ethmoid bulla can be seen, as well as membranous fontanelles and any associated accessory ostia. An angle endoscope is recommended. Nasal endoscopy. This is a necessary investigation for all patients referred for a specialist investigation of nasal or paranasal sinus disease. It is best performed after application of decongestant, often combined with local anesthetic. The effect of the vasoconstriction of the turbinate mucosa will give a useful indication of the reversibility of any congestion. Endoscopic evaluation using a three-pass technique should enable visualization of the inferior meatus, middle meatus, superior meatus, sphenoethmoidal recess, olfactory cleft, septal area, and nasopharynx. Narrow diameter 2.5 to 3 millimeter angle scopes 30 degree to 45-degree confer greater opportunity to look around corners into each narrow nasal meatus. Patient confidence is enhanced by initiating the examination with passes through that the more patent parts of the airway, for example, on the side opposite to any septal deviation. Conditions causing severe obstruction of an anterior airway, such as a dramatic septal deviation or large polyps, may preclude endoscopy beyond this level, but the clinical relevance will be obvious. Examples of the endoscopic anatomy and common pathologic and findings are provided in figures 88.3 and 88.4. Figure 88.3 stills of the nasal endoscopic anatomic findings. A is endoscopic view of the right nasal valve, internal nasal valve, and B is endoscopic view of the right middle meatus. Figure 88.3 continued stills of endoscopic anatomical findings. C is the endoscopic view of the right middle meatus showing the uncinate process, hiatus semilunaris, and ethmoid bulla. D is the endoscopic view of the right side of the nasopharynx. Figure 88.4 stills of the common endoscopic pathological findings. A is the left inferior turbinate hypertrophy in allergic rhinitis. B is the right nasal polyp. C is the severe crusting of the right inferior turbinate and septum in granulomatosis of with polyangiitis. Endoscopic nasal biopsy. Any nasal mass should be evaluated for color, consistency, vascularity, and origin. Bilateral nasal polyps need not be biopsied unless the mucosal appearance is unusual. However, it is sensible precaution to obtain histopathology in all primary polyptectomic cases. Other endonasal masses can often be biopsied in a clinical situation, but the possibility of a vascular nature, example juvenile nasoangiofibroma or meningoencephalocele, must be considered based on the appearance, location, and apparent margins. In such cases, a CT with contrast or MRI scan may prevent significant complications. If a biopsy is still required, it may be best performed in the operating theater. In all cases, preparation should be made to address any epistaxis following biopsy. Best clinical practice systemic approach to history and examination based on presenting concerns, appropriate PROMs used to record presentation and clinical progress patient completed, formally recorded benefits for surgery and other interventions. Future research. Rarely do we formally study our greatest tool, the medical history and examination. In the future, the coming together of medical informatics, the electronic patient record, patient reported outcome measures, and innovative, largely patient led data collection techniques applied to routine clinical practice will bring together a wealth of data we currently fail to recognize and interpret. This will give us greater opportunities to improve our understanding of the patient symptom journey, diagnostic implications, and effect of our interventions truly have. It may also trivialize clinician involvement. Such changes seem some way off yet. A good start would be Rhinology MASH team. Key points: well developed clinical skills in clinical history and examination are key to effectively arriving at the correct diagnosis and implementing appropriate management in all our patients. PROMs have become an integral component of patient assessment. Nasal endoscopy is a necessary investigation for all patients referred to a specialist for a rhinologic examination. Thank you.